going on, with staff here at the office with IRCCO management, some changes for beneficiary attribution, a little bit update on our audit, some of our goals, telling our story, some market share, and some other things like that. So just try to go through, these things in an efficient manner. So if you have questions, always feel free to send me an email, ask a question during the call today. I know Kirby kind of is controlling the mute and everything today, but feel free to raise your hand and ask away. So I'm going to go ahead and get started. I'll be having Jackie and Angie chime in when they can. If not, I'll just go through their slides. As a reminder, we completed the application on July 31st. Thank you to all for getting your applications in. We have 24 hospitals moving forward, 4 independent practices. I was telling the board today, how things change in the past several years. When we submitted the initial application in late 2014, we had, I think, 14 independent practices, and now we're down to 4. So it just shows you how things have changed in our local communities. We're welcoming Jersey Community Hospital and Franklin Hospital, and I don't know if their CEOs are joining us today, but their teams will soon become part of our monthly calls and all our work. As you know, with the application into CMS, just to let you know, they'll be coming back. CMS staff will ask for additional information, so don't be surprised if I ask you about something, but hopefully we've got everything submitted, and the application will be approved in November for our start in January. So we'll speed ahead on that. With the IRCCO management, a little bit what's going on with us. I know the other day somebody asked, well, how did our audit go for IRCCO? And as IRCCO is part of ICANN, and just the fact that ICANN is the member and managing member, our financials are part of ICANN, and we had a clean, unmodified opinion. There were no material deficiencies, so everything went very, very well. Our AIM funding, the CMS gave us some recommendations, and they've encouraged us with the auditors to book it like they do with a grant. So when we have expenses for AIM funding, they recognize that within the month when it's done. So that's all being handled appropriately, and just wanted to let you know that, clean finding, and we're in good shape. It's time to regroup. We'll talk a little bit more about the auditing work that's being done out there in the communities with all of you. Appreciate the time that you've been spending with IRCCO staff coming out and going through what's going on at your facility and how you're adjusting with care coordination, all that. So what we're planning is collecting all that information, all the gaps and the successes, and what we can do in planning for next year. We will have a strategic planning meeting later in October. Date's not yet finalized, and we'll want everybody to come together, and we're going to sit down in groups and talk about this and how we can be successful. Angie and I presented for CMS on August 9th. We were a couple of panel members sharing our story with IRCCO. We were asked to present on what we work and do with rural community hospitals. So it was valuable to be part of that experience and to tell our story. What is going along with telling our stories, one of the things that we realized that we haven't done a lot of telling our own individual stories, our success stories, and I think it would be helpful for all of you to have, what we've done for well visits, what have we done for ED utilization. So we're going to be over the next several months preparing what we call small white papers. They're like 2, 3, 4 pages about some of the success stories that you could share with your medical staff, some of the interventions that you've all done, and really bring it to life. Our benchmarking committees, we're continuing the efforts. I think many of them meet this month, so I don't really have much of a report for that. And Jackie King and I will be putting together a committee to go out for rebidding our IT platform, the one that takes all our claims that we get from CMS, sorts it out, and creates the dashboard. You probably fondly know it as eClinicalWorks. We had a contract for 3 years, and it's time that we evaluate. Maybe they're the best thing out there, or maybe we need to change. So we will be going through that process and do a rebid this fall. So those things are coming along the pipeline. As far as our focus the next 3 3 years. We're like peeling an onion. I've had several people say to me, well, now that we have all our tools, I guess we're all set for the ACL. Well, there's a lot of things that we still need to do, to be really well prepared for value-based purchasing. Population health, Angie will talk about the quality scores. We scored very high in our quality, other than we were a little lower than some of the other ACOs as far as prevention. And all those things as far as helps with keeping our beneficiary costs down, all these things connect together. So we'll be focusing a little bit more on prevention and patient engagement, Medicaid, social screening, and care coordination. Bottom line is, once again, rebuilding your local market share and expanding that, building that patient loyalty. And that's how it's that connectedness and why you want to stay with this particular practitioner, your hospital, and so forth, and giving you support tools to make that happen. So next steps, kind of the next few months, the new renewal application is done. We'll be onboarding with Blue Cross and Blue Shield. Participant audits, you've been working on that. Strategic planning this fall. One of the things that during the strategic planning that we'll discuss is maybe those that want to go to risk, maybe we can spin off a second ACO. Not saying that we have to do it, but these are all important discussion items that we'll cover. I've had an initial call with Aetna about how we might join their shared savings program. We need to focus on a screening tool for like Medicaid and Medicare, these high-risk patients with social determinants. We've got a sample one that we'll look at this fall. Doing more with marketing, and the big elephant in the room is specialty referral tracking. Those patients leaving your ER, those patients leaving your practice going to specialists, and how do you get them back and making sure the recommendations are then incorporated, or the surgery stuff that was done, how is that then incorporated back into the local practice and clinic management. So as we know, we're building the foundation for success tomorrow. It all focuses around the triple aim and what we can do to decrease Medicare individual beneficiary spend and how we can improve our processes. I don't know if Jackie, if you want to jump in there. As we know, CMS put out its proposed rules and provided some updates for rural health clinics. A lot of it. What? Hello, can you all hear me? Hello?
We got the message across. Well, it still shows 38 people hanging with us. Thanks. Sorry, I was muted. Hopefully everybody's able to hear me now. Okay, so I'm going to go over the CMS proposed rules for the beneficiary assignment. As most of you know, the current state in terms of identifying people for eligibility on the pre-step to actually assign to an ACO, they can only currently use the services when a claim comes across with a physician's NPI number. But what the CMS proposed rules are going to allow is that our HC claims, regardless of physician or mid-level, are going to be allowed to assign a beneficiary to our ACO in that pre-step. So that's huge. This is still proposed. The comment period ends, I believe, September 21st, which is about the day for our next call, actually. So with that, we will have less healthy patients missing the boat being in our ACO right now. We're fearful that many of our very more healthy, lower cost patients are not being even attributed to IRCCO because of the fact they're seeing a mid-level all the time as a primary and not getting a claim in 12 months from a provider, a physician. So this is the hope that we're going to start to see our numbers look differently, be less in the red, more in the green, because we're capturing those healthy patients that truly are seeing our providers that just are not being attributed because of this loophole in the original way they set up the shared savings program. Can you hit the next slide, please, Kirby? And Pat doesn't appear to be called in. I don't know if she could call back in. Next slide, Kirby.
Jackie, which slide do you need it to be on?
I can't move the slides.
Right. Which one do you need it on?
It should be on 9. Just go to the next one, please.
I'm going to have to. That's slide 9. Oh, God.
Are we sure it's not Monday?
Yeah. It's on slide 9. Is that not the correct one?
It's not showing up for me. I don't know if it's showing up for anybody else.
I can't hear it in advance.
If you want to make me the presenter, I could probably pull my own. There we go.
Yeah, I'm trying to. Something's frozen up. I don't know what's going on.
Okay. Well, we've got the on-site visit of IRCCO staff. And Angie, I don't know if you're on the call. Are you on the call? Okay. Since I'm able to talk, I'm going to go ahead and talk. So we have almost completed our 24 audits to our on-site facilities. The team consisted of Angie, Lindsay, myself, Trudy, Colby, Krista Fisher, and Lisa, our CCM specialist. And we have learned a lot. I think that the team sending out the audit tool ahead of time just brought an aha moment to a lot of people to realize all of the things that are part of being in IRCCO. And the feedback's been wonderful. Remember that we are your team and we are here to help. If you're having trouble with eClinicalWorks data, your regional care manager or myself or Lindsay are here to help. Inside of that comes to identifying your beneficiaries for care management. It doesn't have to come from eClinicalWorks data. It can come from your own internal data as well as eClinicalWorks. It can come from one of your primary care doctors. So there's a lot of things that can add to choosing your patients. So we want to be able to help you in any way. Locating your top 20 high volume and high risk patients. Who's your point person? Who's your leader? There's all of these questions that we've been asking and kind of making you take a look internally and seeing what's going on inside your walls so that you can help move this forward, move the needle, and potentially share savings in the near future. We talked about the transfer and specialty management process. We've identified some potential gaps there. Great stuff. Also, we've identified during discharge program, the discharge talks about how are you handing off patients from discharge to the clinic. We'd like to try to get some case studies still about are we making a difference? Is IRCCO making a difference in your life, in your patient's life? And then we talked about during the course of our audits, if you're doing or considering doing transitional care, advanced care planning, CCM, all of those items are stuff that we've asked and that you've taken a look at, and we hope to be able to pull back, meet as a core team at the end of August. We're going to take the entire audit tool and weight the different sections and then score everyone individually by weight, and then take that information and move ahead with reporting back to you individually, as well as coming up with educational opportunities to help the whole organization keep, again, moving that needle forward. The process and review, again, I think I've just talked about all of this. So the bottom line is, how can we improve? We'll take those lessons learned, we'll bring them back to you. Angie, are you on? If you're not, I'm going to do my very best to talk about this quality report. So we had a Care Navigator meeting about 2 weeks ago, and we discussed goals. We came up and voted and made goals for our Care Navigators and our care coordinators to be following to help improve our scores for our quality. One of the first goals is the HCC greater than 2. Angie's calling it the greater than 2, the Jackie goal. That is according to the HCC risk stratification scores on eClinicalWorks. We feel that everyone's patients are at least at a 2 or more for being in the severity of illness. So those that are under 2, we'd like to have a look at your coding, your documentation procedures, et cetera, to see what we can do to get that risk score properly identified with your claims. The ER measures that were selected, folks that have no primary care doctor, assigning a no doc to a primary care, getting follow-up phone calls to those folks that left the ER within that 48-hour window, and reviewing of meds, and did they get their meds, are they taking them correctly, and how are they doing with keeping their provider appointments. Then we're talking about patient education, and that's part of our CAP scores, to make sure we're giving the proper patient education for the various diseases, et cetera. Screening and follow-up for depression, which is under prevention that Pat had mentioned earlier, and then also that diabetes, hemoglobin A1C, and composite score. Those 2 measures are things that the team decided to work on as a group. The quality measures come in 4 domains, which are listed right here. Here's the points possible from 2016 versus how we scored. And you can see our lowest is actually in the prevention area. Pat did mention that earlier. So these are the patient caregiver experience. The ones that Angie has highlighted in green are the ones that we are going to be focusing on, I think. Sorry, guys, I'm trying to do the best I can with her information. This is just a snapshot of what we get back, so you can see the actual questions being asked and what the scores are and the mean and how we're doing and whether we're going up or down. Again, this is just more of the questions of what they're asking and the mean score and how we're doing, whether we're trending up or down. So you can see the red and the green arrows. Patient safety, with the significant decline in the heart failure measure, We don't want to see any of our scores decline, so we definitely want to make sure that as we're moving toward other indicators, we're maintaining or in keeping up with the ones that we've already done a good job with in the past. And then here's that the blood pressure follow-up has gone down, and we want to be sure that again, we're keeping that up and making sure everything's out. And these are the deep dive. These are some things that we've improved on. These reports that you're seeing snippets of, these are embargoed, which means we can't share them outside of the organization, but we can share them with you as members. So,
Jackie, this is Pat. Can you hear me now?
Yes.
Jackie? Okay, great. Sorry for all the details. Did a great job going through. You want me to take the compliance for you?
Yes, please.
Okay. I'll let you advance the slide so we don't have any glitches here. We're still looking for somebody from finance to jump in and join our compliance committee. So if there's any of you finance folks that would like to be part of it, one of the things that ACO has to do is have a compliance plan. Of course, with HIPAA and all the compliance programs that you have, as far as the integrity of the billing process and the coding and so forth. And because we're all in this together, we have to make sure that each party, maintains their own responsibility. So we hired an attorney firm from the St. Louis area, Margaret Scalato and company. They're specialized in compliance. And she and Angie and Ada Bears, who's our chairperson from the board, and they've worked together and put together a plan. And we will be having a manual that'll come out with the different guidelines and covering auditing and monitoring and complaints and things like that. So all those things, will be coming together. We know you probably have been wondering, well, do you have a compliance program for the ACO? Yes, we do. We have some programs in place like any others, but we're now fine-tuning it, and it's part of our responsibility. So next slide. Okay, the biggest risk of an ACO, like I said, that's, the accuracy and the quality assurance and making sure that we're all involved in the process. And so with that, there'll be some training that'll be done in each individual site that will be just a few questions that you'll have to update each year. So it's all coming together. So next slide. Try to move through this. The biggest probably thing is that if you have complaint, that whistleblowing, all those things that you have in your organization, that people in the community or patients or doctors or practitioners, staff, whatever, if they're aware of a concern or complaint, that they can actually register it. And of course, those things can be done through our website, and we'll be posting more of that and sharing more information as this process finalized. So next slide. Okay, Jackie, it's back to you, understanding your data. And there's a picture of you.
There sure is. You snuck that in on me. Okay. So basically, I want you all to know that if you have questions about your data, let us know. Let your regional care manager know. Let me know. Let Trudy know. We want to help. We want to be sure that you have the right provider and tax ID numbers. If you are looking on eClinicalWorks and you're missing a provider and you just can't figure out why they're there, let us know. If you have, if you're just not finding claims for somebody, or if you have a provider that's been gone for more than a year, let us know, because there could be some things we have to check in the background to make sure that the settings are correct and we're properly displaying the right providers, the right tax ID numbers, et cetera. If you need help drilling down into the data to learn more about your beneficiaries, your practice patterns, your targeting, getting yourself lists, we can certainly help you with that. I just got a call before I got on with you with the hospital. I'll do it over and over if I need to. It's one of those things that if you don't use it, you lose it. And it's really good information, and it really does help you trend and give you indicators. So we want to help make you successful by using that claims data. And with that, please remember, it's not real-time data. It's historical claims data. So you're at the mercy. Remember, when your patients are assigned to you at your location, they can go to other hospitals and have care, and you're still responsible for all of those costs as well as what happens within your four walls. So you're at the mercy of however long it takes those hospitals outside of your walls to get their claims paid and then get them back from CMS, and then we have to upload them to eClinicalWorks. So it is not real time. So keep that in mind. It is pretty clean data, but again, there can be variances. the most recent thing we found was that they were assigning, eClinicalWorks was using old logic that was assigning patients to pretty much hospitalists or folks based on swing bed doctor visits. Swing bed doctor visits have been excluded as of the 1st of this year as being one of those pre-step attribution steps. They feel that if they're in a swing bed, they're more of a hospital patient than they are an outpatient, so they are not using that as a primary care visit. So that's just an example. Someone in the hospital kept saying, this is a hospitalist, she shouldn't have any patients. She hasn't seen a patient in the clinic for a year. And I dug down and realized that there was an issue. So do keep that in mind. It's not perfect. It's there to track and trend, and we are all here to help you. That's what I want you to get out of the slide.
Chronic care management, Lisa's still available to help you at any time. It's a turnkey approach. If you haven't gotten a copy of the manual to use to develop your own program, please do so. I know I was going to have Lisa on the call today, but she's doing some consulting work with some other organizations in Texas on the phone, and so she's not able to join us. But please remember, this is a new program. It's a chance for you to develop. She can come on site and give you the guidance, and then your regional care managers can help support you. You know, the goal is you to have the tools, as Jackie said, for your program. We want you to be successful. I know some of the hospitals are trying to decide, do you charge, do you not charge? And this is a discussion that we're having with CMS, ICANN, and other organizations are having with CMS, because we would like to take this off, you know, as far as the beneficiaries having to, you know, charge the beneficiaries. And this way it could be similar to an annual well visit, because this is really the future, that we're going to have to do more care coordination. So I really hope that you have a program in place. I know some of you have been doing it for a number of months, and we've learned a lot from you. You've done a great job, and those that are ready to jump in, let's you take advantage of this resource for you. So next slide. Changing accidents, action, you know, we want to make sure that, you know, we're hearing from you. It's those frontline stories. It's the commitment. Why are you doing this? Why is care coordination important to you? Those are the things that I hope you share with your community, what a difference you've made in coordinating. It's those stories we keep reading about where, you know, they found out that somebody had been in and out of the hospital for many, many times, and they realized through care coordination that maybe they had to go up and down steps, and they couldn't take their oxygen with them, and they were, you know, congestive heart failure and COPD, and that's why they were in and out, because they can't have their oxygen. It's those things that you find out about your patients, that you make a difference in their care, that we want to hear about, and that you need to be telling your community what a good job that you're doing. Next, I want to move into the hospital market share with IRCCO. We've talked about this a couple of months. Hervey Davis has developed this wonderful program through the support of IHA's comp data. We've been able to take all your data and create inpatient, outpatient. This is a separate file. This is the one I used last time, but shows you ED visits, inpatient, outpatient, you know, all these things. You can have your own individual information. You can even fine-tune it with other reports and worksheets that you have, the DRG breakdown from inpatient data, CPT codes, and all these things. It's really at your fingertips. There's no cost to that other than giving you access to your system, and it's a wonderful flexibility to it. I know one of the hospitals even wanted to be able to use it to drill down to show price comparison, and that can actually happen. So I encourage you to take advantage of that. You know, find out those competitors in your area and find out how you can monitor and watch your market share. When you add a new physician, when you're making change in care coordination, is there an impact? And I think we have about half of the ACO's participants, half of you have signed up, and Herbie has done this education. The other half of you, I really encourage you to take advantage. We've got funding that can cover one-on-one training with Herbie, and after the end of this year, I'm going to be working with Lindsay and I. We're going to be able to do these reports on a quarterly basis. Herbie's training us so we can do that. But if you want to do your own individual reports, please take advantage of this. Those that have had have found wonderful market share reports. Let me move on to Blue Cross and Blue Shield. Whoops, there we go. With that, we have our really our official launch meeting next week with Blue Cross and Blue Shield. Right now we have over 14,500 beneficiaries assigned. That's hard to imagine. That's really a good chunk of them, considering with our ACO we have 25,000. Jackie and I have been talking. We think one of the reasons we have a good number assigned to us is partly because, you know, it's the second best payer, but is that Blue Cross and Blue Shield recognizes all practitioners. And so there's some value in having that. But we're going to have to learn. You're going to get more real-time data. You're going to get data within that first quarter because claims are moving in and out. And you're going to be able to measure how you're pricing and how you're keeping your patients. Are they going from your emergency department to somebody else's? And so we'll be measuring and dealing with that. So So with that, you know, be aware that we've got upcoming programs. We have another round in September. We have our board calls at 9:30. If any of you would like to join, I know we'd love to have anybody. We're more than welcome to participate. Send me an email and I can get you lined up. We'll have our participant webinar again at noon, and I promise it will go well. We're actually looking at some other WebEx types of programs. So this is, I think, the second time we've had this happen within this past year. So I don't know if it's a glitch with our phones or a glitch with WebEx, but we do like the idea of having the webinar so that you can get factual information every month. And I apologize for the drag that happened between, you know, from one presenter to the next and losing the call. Thanks to Jackie for jumping in there. So stay tuned for next month, September 21st, 28th. We'll be having a PCMH workshop. Our strategic planning meeting is tentatively scheduled for October 27th, and the Care Navigator December 1st. And there'll be other upcoming programs, but just mark your calendar. We have a participant call, like I said, once again, a reminder, September 21st, and yes, we can. Great things going on in every facility. We've heard wonderful stories through the audits. It's amazing what you've done, and we're going to start telling our story. Make sure you're telling your story locally. I've seen a couple of hospitals that have done some marketing about care coordination, and so this is your opportunity to really keep those patients locally. If not, if there's no questions, we'll adjourn. Any questions? Okay, once again, thank you for your time. We appreciate that, and good luck this next month, and we're looking forward to getting we hope to get our financial results from CMS from last year. Last year we got it early June, and now we hope to get it early September. So anyway, have a great rest of the day, and thank you again for your patience. Bye.
Bye.